is the big side, not the note side, even though there's no notes.
Mode.
So hi everybody. Today we're going to talk about confidentiality in the group setting. So what is confidentiality? Obviously, a lot of us know about it. We talk about it a lot, but it's a state of keeping or being kept secret or private. But in thinking about confidentiality with group, it's something that we should be discussing in group frequently, especially with open groups. So open groups, it's folks coming in every week. And I know here, one of the big things that we do is make sure that confidentiality is discussed at the time of the drug and alcohol intake. It is part of our agreement, which is here on this side. So, we make it very clear from the beginning that how serious we take confidentiality, because we know that if folks are not able to be confident in us, that we're going to protect their privacy, they're going to have a hard time opening up and sharing about some of the things that we ask them to talk about in therapy and where the discussion in therapy sometimes will go. So also thinking about, we can't do confidentiality now due to COVID without talking about confidentiality with telehealth. So here are just some of the things that I have found that can be beneficial when talking about confidentiality in tele. So we want to be in a space free of distractions, where they can speak freely. Wear headphones or keep the volume low to prevent others from hearing not just what's being said. Obviously if they have somebody there, they can choose to kind of monitor what they say, but they can't choose what others say. We want to ask others in their environment to not disturb them during the group. So sometimes it's a little tricky, especially with kids are involved. I know doing individual therapy over tele, it's not uncommon to have little kids running in, yelling mommy or daddy. And sometimes, those crises come up. We want to form policies around call-in and video on-off options. I know at the start of COVID, as we were trying to figure all this out with the fast turnaround, we did allow call-in options. But as folks were able to get this figured out, it was one of those steps we did away with. And we do encourage all videos be on, just so we can see who's in the room, make sure we're monitoring that to the best of our ability. We want to create detailed consent forms so patients are aware of risks, benefits, and limits to confidentiality. As the next one says, telehealth sessions are conducted outside of a controlled office setting. So we can't always control who's going to come into the next, who's going to come into another group member's room, although we do our best trying to encourage that not to happen. And then how to handle breaches in confidentiality, including non-group members coming into the room and overhearing a meeting. So we'll do verbal reminders, and then we can also boot folks out of Zoom for violating confidentiality. And then obviously we also have to talk about when we can break confidentiality. So in certain circumstances, we can override our duty of confidentiality to patients, as long as it's done to protect their best interests or the interest of the public. So information suggests a patient or client is at risk of harm to self or harm to someone else. We can also report for child abuse and adult abuse, neglect, financial exploitation. In these instances, it is important that we discuss it with clinical supervisors or administrative folks, just to make sure we're making the appropriate referral, and that we're also making it within good faith. As long as we're making it within good faith, we are protected. And, in these situations, I only had to do it, I think, twice. They're never easy situations to have to do it in. So, I'm a firm believer in reaching out and talking with other folks about it before just jumping right in, unless the situation were to require it, obviously. And then potential breaches too. So a group member attending group in a non-secure location where a non-member can see or hear, a member recording or taking a screenshot of group members a member using recorded material to share the identity of or blackmail the group or a specific member. Those are obviously very bad things. I know, we have our medical assistants who do a lot of pre-screening questions before the providers come into the room. And they do a great job. If they suspect that someone's in a room, they can always ask them to do a camera sweep of their room to just kind of check with that. We always do we try to always do verbals, making sure you're not recording any of the information. And Zoom is lovely because it tells us when Mitra or Elizabeth hit the Zoom recording in option. It's always really tempting to just hit leave room. You're welcome.
Trying to really get out of this, huh, Phil?
Listen, I sent this to Mitra last night at like 10:30, I think. So I can tell what kind of week it's been. We really do want to try and address these potential breaches before they become a problem. And same thing with confidentiality. It's always better, I think, to over talk about it than it is to under talk about it and then have to dig ourselves out of a hole. Wrong button, sorry. And so some discussion questions. So here's to hopefully having a discussion. So what are your agencies doing to monitor for confidentiality within the group setting, especially through tele? We can either chat or unmute.
And if anyone chats in, I'm happy to read it out loud. So just let me know.
I know what we've done is go over the group rules and kind of say, no one's supposed to be around. And then in times when we've suspected something, we've done the room search and actually found someone smoking, vaping weed with the buddies in the room at the same time that was going on. So we had to end that session for that person.
Yeah. And then the processing after those situations too. What else do others do?
It's interesting. We've been doing in person for a long time now. And the week before last, we had a situation with the building that we had to quickly convert everything to telehealth. And so we did. So it reminded me of how dicey it is when people are. So one person was in Walmart walking around. I said, you can't be in Walmart. You have to go out to your car. And so I'd say that we address it more when we're doing telehealth, and this is helpful. I think we'll start just talking about it in person as well as a reminder.
Yeah, and it's kind of that controlled versus uncontrolled. Gets tricky. I know even with individuals, it's like folks are walking around and you're getting one of these while they're doing dishes and folding laundry and all this other stuff while you're trying to talk to them about the past. Yeah. Who else?
We kind of address things just periodically. I don't know if I would say regularly, but just every month, couple months. But I find it more so we've been doing a lot more in person, and you just tend to get those questions of say if one person in a group has been there for a while, transitions to the next phase, you're going to have those people question, oh, where's this person at? And you might just go over, whether or not you talk about somebody who was in a group but is not in your group anymore. I always kind of find little scenarios that kind of bring it up as a good, let's cover this again.
Yeah. Kind of work it in any opportunity you can.
Yeah, we kind of do the same thing. At the beginning of group, we remind everybody the confidentiality boundaries and make sure that the information they share, if it's construed, they would not mind it if it, won't hurt their feelings, to be more conscious or more mindful of what it is they're talking about before they start the discussion.
Mm-hmm. So some of you already alluded to the second question, but how have you handled an issue pertaining to confidentiality within group? Does anybody else have something to contribute to that question?
Well, I think I might have blended the two questions.
That's
So
okay.
if someone starts to, say something where we're like, wait a minute, that may be a little bit too detailed or too in depth or too personal, we go ahead and jump in there and be like, make sure, you're more mindful of what you're saying and what you're sharing, because we can protect what our own person, shares outside of group or doesn't share outside of the group, but we can't control what other members share that they've heard.
Mhm. And it's definitely a fine line with oversharing and undersharing, and
We also, I feel like we live in a small community, and so encouraging patients to come forward if they know someone in the group and they don't feel comfortable. It's okay to so kind of presenting that generally before it necessarily comes up. It's okay to approach the group leader after group and just say, hey, she's my cousin, or this happens all the time. And then people are just silent, and then they just stop talking in group, and you're kind of like, what's going on with that person? That it's okay. We will find, another spot for you or a way for you to participate in treatment that doesn't feel uncomfortable, because we just feel like there are definitely situations where people know each other, and it's hard to create a safe environment if there's a lot of history there.
yeah.
Yeah, that's very true. We actually had a situation where it was a husband and a wife, but we didn't know at first the different last names. And then when we found out, we split them up. The sharing just increased dramatically for both of them, because they were actually thinking of getting a divorce, but didn't say much to the group.
We had actually through telehealth found that we had a couple in group that were just roommates that led into some difficulties.
Yeah, we don't have people in the same group if they're a couple. I'm curious about, I think Derek just mentioned this. So it comes up not infrequently, that someone who has somewhat bonded with the group isn't in the group in a subsequent session for one reason or another. There are a lot of different reasons, and I tend to just not say anything about it. But then it, it comes up, and often when people, so I'm in the the medical part, and then often when they get to the group behavioral health session, I think they feel a little more free to talk about it. And I know our counselor is really careful about not disclosing confidential information, but she does help people to process, because sometimes people miss somebody who's been there. And I find that a really awkward one. I don't really, I don't, you're not going to announce that somebody's no longer in the group, but it's a glaring deficiency that you don't say anything about it. So anyway.
Yeah. I think it's one of those tricky ones, and I don't know if maybe Laura would have another thought, but I know when that's come up in my groups is I always just bring it back to confidentiality. There are things that we can't talk about from a treatment team perspective, and if it were to happen to somebody else, we would honor everyone's confidentiality with that.
Yeah, and we will sometimes make general statements like, we've been working with this person, and if it's true, like, we have stayed in contact and we're working to get this person the best, whatever they need. So just a very general statement that they're not dead, because people worry about that.
Right.
And usually when people have overdosed and died, the group members know, and so they're the ones who share that. But they, when somebody just disappears, it can be really scary. So just an assurance that they're okay, or that we're not quite sure what happened. I mean, just to be honest, that's not disclosing anything other than, like, I have no information to share. We're not quite sure where they are, and we're continuing to try to reach out to them, something like that.
We had somebody die not from an overdose, and it was really awkward to not acknowledge, I guess even acknowledge it was awkward. And then people found out a long time later. Anyway, something to keep working on.
Yeah, I don't think those conversations ever get easier. Yeah. Other thoughts on how you've handled an issue pertaining to confidentiality within group? And then what about outside of group? So as providers or case managers, or therapists, you know, like we talked about, we are a small town. Even Morgantown is pretty small. We all shop at the same places for the most part. How do you interact, you know, when you see your client out in public, how do you interact with them and how do you set that boundary and protect confidentiality?
I kind of let them make that call. I wouldn't say anything unless they like, oh, hey, Derek, how's it going? And I'll be like, oh, hi. Or if anything, might just do a head nod. But I kind of like go over things with people in the beginning of like, if I see you out somewhere, I'm not gonna, oh, hey, Joe Snuffy, who's in my addiction counseling group. How you doing today?
Poor Joe Snuff, he always gets thrown under the bus.
I know, right? He didn't sign that HIPAA contract, so we're good.
Okay, that's good. Yeah,
I
so
know-
I'm sorry, someone go ahead.
No, I was just gonna say in some of my groups, like one of the providers that I work for will just say, hey, you know, some of you I see have seen around. I just want to let you know I'm not going to approach you or talk to you unless you want to talk to me. It's not that I'm actively ignoring you, but like they'll just come right out in group and say like, I know that I've seen some of you around. I wasn't ignoring you or anything. I just want to maintain your confidentiality. So I think that's a really good way to kind of address that to everybody as well.
Yeah. Yeah, my favorite's when you make eye contact with them and then they don't want to, you know, acknowledge you. So they like stare at you and then they look away. But those are all good boundaries.
Another riff on this theme is, taking care of family members. So I'm in family practice, and so I take care of a lot of parents of people I am the family provider for the parent of a child who's in MAT, and often the parent knows, but that doesn't mean I can talk about it. And so there's this kind of dance around, they know I can't talk about it either. But I find that sometimes parents want to acknowledge, they'll just say, thank you, or they'll say, and I just, it's not any really that different from confidentiality in a family practice setting that you've been in for a long time, where you're taking care of extended family members. You have to learn a way to, not disclose while still, taking care of the other person. The other thing I was going to say is that one confidentiality issue within group is if I know that somebody has disclosed to the staff that they have hepatitis C, and this would apply to HIV as well, I never talk about it in group, but I talk about it generally to the group about the infection and let them know that I can treat them for that. And it's, a great conversation piece within group anyway. So I figure everybody can learn from it without identifying the person.
Yeah. Anytime we can do it, and I know Laura had mentioned it too, just those general statements for psychoeducation standpoint can go a long way. You never know, maybe they have a close friend who has hep C, and that information might not necessarily help someone specifically in group, but it could touch 3 or 4 different lives just by what we should, providing that education and what options are available. And any other thoughts pertaining to discussion questions?
One area that I see an issue of confidentiality being very needed to carefully protect is when colleagues or people that are employed by the hospital where I work or the clinic where I work are under my care. And so you have to make it safe for them to feel like they can get medical care and still be part of the system and provide care to other people.
Yeah. And so using, for us, it's using those satellite clinics, right? Where we can put that staff member with a provider that they're going to have limited interactions with, and so they can open up and communicate in that way. That's a good point, Dr. Hirschler. Any other thoughts? Cool. Well, that's all I have. There's some websites.
Thank you so much, as always, Phil. That was a great discussion. Super important topic, clearly, as everyone has experience in it and something to share about it. So we really appreciate it, Phil. Thank you. Were there any other questions for Phil, comments? Jen, I noticed you have muted.
I do have a question. So this came up just last week in medical group, that we had a new person in group. I had only met her by telehealth, and so it was my first time meeting her. And generally I go around the room and have the new person. I have a conversation with the new person last, just for them to see how it goes. But anyway, she had denied any relapse, but her cup had benzos and THC in it. And so I just said that I treat the urine drug screen. Most often I treat the urine drug screen as not confidential in group. I treat it as something that, they've given, and it's part of what we report to group is, has there been have they had a relapse? Have they slipped up? Are they still regularly using? And I see the screen as part of that. And so just talking about it in a non, accusatory or judgmental way is my usual approach. And I just, is that the right thing to do?
Yeah, so we actually started to have this discussion recently, like, are we clear enough in our agreement so that people understand that their urine drug screen results are going to be shared in group? Like, do we actually say that explicitly? And we've been talking about potentially adding that more explicit language to the agreement that people sign, so they understand that all of their treatment takes place in group, but they may not really understand the full implications of that. And so it's interesting that you bring that up, because we've been kind of kicking that around as well, because they don't, well, I mean, now that we do swabs, and so that is the actual drug screening is done in a group setting. Obviously, when you're doing urines, it's not done in a group setting. So I think there's a little less confusion when you're literally doing a swab in front of the whole group. But I think we're going to add more explicit language about drug screening being shared in group.
I take a very matter-of-fact approach about drug screens. I say, if you were going to treat somebody's hypertension, you'd have to measure their blood pressure. Or if you were going to treat someone's diabetes, you'd have to measure their blood sugar. And it's, to not discuss it is kind of enabling a dishonest relationship with the group and with the clinician. So I'm very matter-of-fact about it, and just this is part of the information that we have, and how can we make sense out of what's going on.
And it actually, go ahead, Adina.
Oh, I didn't want to interrupt you. You can go on, Priscilla.
I was just going to say, last week in group, we had 2 people do swabs, and they both tested positive for oxy, and they both said that they didn't use. So they actually bonded over, like, needing to come in and do an in-person screen, and they reassured one another, well, I didn't use either. And I actually believe it was probably a false positive for both of them, although we don't know, but they were able to actually, it had a positive effect that they both had tested positive and said that they had not used, and supported each other and reassured each other.
Yeah, and just to add to the urine drug screens for newcomers with weed and benzos, I mean, they could be positive for several weeks, right? And so I think it is important to say, hey, we're going to treat the urine drug screen, and as long as it's positive, it's not cleared out of your system, but we know you may not be using. But then let them know that you are going to talk about it. Because what some people would do is use weed, a couple of weeks, stop, and go, oh, it's just still in my system, when it should have been cleared by a month or two.
I was just going to say too, Dr. Hirschler, what you mentioned about taking a very matter-of-fact approach. I'm not a clinician, but I would imagine that it would make it almost less stigmatizing to do UDS, within the group. And Laura, like you shared, 2 patients kind of bonded over it. So it could be positive outcomes too, but that's really interesting. Thank you all so much for sharing that. Dr. Hirschler, was there anything else you wanted to add? I noticed you had unmuted.
I was just going to say, that I kind of think things through with the patients. We make sense out of the situation they present with. And so that's just part of the information that we have to make sense out of what's happening and how to move forward. So I think they appreciate kind of just being sensible.
Well, thank you all so much. Were there any other thoughts, comments, questions? We do still have about 30 minutes left, so we can take advantage of the time, maybe do some informal de-identified case scenarios. We can have a nice open discussion. Derek, I noticed you unmuted for a brief second there. If that was a mistake, sorry for calling you out, no worries.
No, I'm used to being calling out on things. I had a thought, but I don't know. We also will cover monitoring levels in urine if it is something that's shown up over time, especially with THC, and talking about with the clients how we're seeing it trend down. But in cases like that, someone's like, oh, okay, yeah, good, it's going down. That means one day it's going to be not there. But with Delta 8 and Delta 9, we've not had any luck with showing levels. Sometimes it shows up as there's some kind of chemical intervention, inconclusive, or all these weird things that pop up. So it'll be there and probably hang around for a while, but we can't measure anything on it. And then that just leads to frustration on probably a lot of different ends. So that was something that kind of had me thinking about that.
I was going to mention that. So we have somebody who I know for a fact has not used any kind of Delta 8. Delta 9, by the way, Derek, is regular THC. So if you say Delta 9, it's Delta 8 and Delta 10. Those are the 2 synthetic ones. But Delta 8 in particular, we had somebody who hadn't used for 4 months and they were still testing positive for that. And they were in a controlled setting. So I don't understand it exactly, but I have a feeling like the human body is not really meant to metabolize Delta 8. So it's a concern because it really does throw off drug screens, possibly for months. That's something we've talked about internally here, is how to test for it, because there is no definitive test to test for Delta 8 or Delta 10 for that matter. And it's certainly throwing things off considerably. I hope it is made illegal soon, similar to synthetic marijuana, because it is causing some serious problems. But it's still there. So
Thank you. Buffalo Plaid brother.
I love that. That's awesome.
Derek, you get me one of those Buffalo Plaid buffaloes, I will put it in my office. I promise you. I will pay handsomely for it. Thank you.
I think I can make that happen.
Please.
We all have to invest in one of those for sure. Tony, I noticed you unmuted before. Did you want to mention something as well?
Yeah, I have a question, and it's certainly about privacy. It's kind of a peripheral question, and this came from we're in the second cohort of an ECHO process with drug courts and family courts here in West Virginia. And the very first week, the facilitator did a case presentation, and I've been ruminating about this since. And one of the issues in the case presentation was a participant of drug court had signed a medical release on their end to allow an exchange of information between the treatment clinic and the drug court. But the treatment clinic was not releasing the information to the drug court because the treatment clinic was saying that they did not execute a release of information on the treatment clinic side. So I wondered what people that have been doing this longer than I have and that may have been working with drug courts or family courts, if you've had a similar, I mean, obviously they have a lot more power. I mean, they could, place them, they could incarcerate them or kick them out of drug court. So there's a compelling reason for the participant to want to exchange the information. But have you had that situation? And what have you done with that when a drug court or family treatment court is continually asking you to release information? They have a release, but you don't from your end. Has that happened to anyone?
I've had that, yeah, and I don't release it unless the patient says they've assigned consent, because even though they're drug court, they still can't get it, legally speaking, right? The patient has to consent when it has to do with substance use.
Yeah, that was my thought too, unless there was imminent danger, imminent harm. And I think Phil talked about that, which, just participating wouldn't, unless we were aware of additional circumstances, wouldn't be imminent danger, I don't think. But I just have been obsessing about why that happened and what I would do if I was in that situation, and, what the regular policies are, other than maintaining that privacy unless you're aware of something scary going on.
Well, see, we were lucky because our client didn't know they had to sign on our end as well. So they just thought they had to sign on that end. Then we brought it up to them. They're like, oh, sure. And they just signed it. But until they signed it, we just didn't do it.
Oh, so they thought just signing on. Oh, okay. Yeah, that would be interesting. They thought they already took care of it and they really hadn't.
That's what I was gonna say. My thought on the why is release of information. Things are very complicated, and sometimes I have to sit and walk clients through it because they're just like, what do I put here? And I'm like, that's up to you. It's not my say.
Yeah.
Tony, we've been working with our family treatment court and adult treatment court here in Fayette County for about six months, maybe a little bit longer. And it was maybe longer than that, maybe a year. But anyway, it was a huge issue to me and very awkward. And so anyway, actually, I think I got help from the hub a couple of sessions ago, and I checked, and we have them sign a release when they enter our program that states that that's a release. And I have started talking to those people about it at induction because what it created for me was this really uncomfortable situation where I thought it was really hard to establish trust with them, because I attend the adult treatment court occasionally, about once a month. They meet weekly, and I can't do that. But so they see me in clinic, and then they see me in the courtroom, and so I explained to people that what we share and what we don't share too, so that they can have some confidence that they can disclose confidential information, and it's not just going to automatically be announced in the courtroom. And then we also send a weekly encrypted message to the caseworker. It might be a probation officer, but at any rate, that just says the client's in good standing, and that was helpful feedback to get actually from this group on a previous echo for me. So I think that's one of the more awkward things, because I love having this collaboration with the adult and family treatment courts, and I also really, my hat is off to Project Echo, because I just think it's a tremendous use of Echo to work with that part of the, the judicial system. And I know our judge here went through ECHO. So and it's a real, and at least in Fayette County, it's a privilege to be part of it. It's a really excellent team to work with, but you gotta be really careful.
Thank you, Jennifer. I'm glad you're working with them. I think that would be a fabulous collaboration, and I will touch base with you off line sometime because I would like to hear how that goes when you go to the adult family treatment court. It's fabulous.
Anyone else with any thoughts or questions or discussion points?
This is an aside for Derek, but I was trying to figure out a good sign for buffalo plaid, and I was looking up the American Sign Language. So it's like this, and then you do a 4 across your chest and down. So we might have a sign though. But I appreciate everybody.
I need to practice that.
It's like a moose.
Yeah.
Yeah, it's this, and then you go across and then down. So
Man, we should use that as our shout out for our ECHO group.
very good.
I want to make a GIF of it.
That sounds good. I love all these ideas. All right, so for next session, you guys are gonna do introductions with those signs, okay? Alrighty, well, I don't want to hold you all longer than we have to, but it has been such a wonderful session as always, and I learned something every single time, so I really appreciate all of you so much. The only announcement that I have is that our next session will be on November 22nd, and Katie Chasson-Downs will be presenting on group therapy. So keep an eye out for that reminder. Feel free to shoot me or Elizabeth an email if you have any ideas for that session. I know she wanted some input from all the participants. I know we haven't had a case in a while, so if you have even questions to bring to the session day of, we're more than happy to have that as well. So thank you all so much, and we'll see you guys next time. Thank you.
Thank you. Bye-bye.